Today we're going to talk about obstetrical emergencies. First, we're going to discuss normal pregnancy and the normal changes and things to expect. And then later we'll go into things that can go wrong during pregnancy, and we'll go into actually mechanical problems with actual birth emergencies. Starting off, let me tell you a little bit about myself. I'm Dr. Ira Wood. I'm an emergency physician at Cedar Park Regional Medical Center. Through their EMS education program, they're kind enough to sponsor me for this presentation. Clearly located in Cedar Park, and we've seen many of you there in our emergency department. And thank you for having me and allowing me to give this presentation. What we're going to talk about in this first part of the presentation is birthing basics, basically addressing the aftermath of the birds and the bees. We won't cover the birds and the bees. Dr. Jarvis will be happy to answer any questions that you have about that component of pregnancy emergencies. So where we're going to go with this today. One thing we're going to talk about is fears and anxiety. A lot of times pregnancy-related calls are some of the things that scare paramedics the most. I know I was a paramedic for a while, and I would rather run a gunshot wound than a normal delivery in a lot of cases. We're going to define some of the non-EMS terminology and discuss its importance. This is not going to be a vocabulary lesson just for the sake of vocabulary. It's going to be some things that will help you, especially if you're on calls involving midwives or transfers and things like that. It's just good general information. And then we're going to talk about stages, review the stages of labor, the normal stages of labor. And again, this is semantics. I don't expect anybody to call in a radar report and say, we're inbound with a 23-year-old, G3P2 in stage 3 of labor. But it's a good way to organize our discussion about normal childbirth. We're going to discuss the relevant aspects of assessing the pregnant patient. And really, this is more common sense than most of the books make it out to be. And we'll review the playbook for a normal delivery. That's what we're going to see most of the time, and that's what we should be prepared for. Like I said before, most of us are kind of intimidated by pregnancy-related emergencies, and we kind of look like the good Dr. Ross here in the corner when someone tells us that's what we're going to deal with. Here's a quote from one of the resources. It says, "The anxiety experienced by emergency providers caring for a woman in active labor is not simply due to the lack of familiarity with normal deliveries, but also due to the awareness of potential for serious and rarely fatal complications of labor." And so there are bad things that can scare us, and we don't do the good things very often. So we often, you hear about the bad things, and that's how everything works. You generally hear more about the bad things than the good things. And those pre-hospital complications, this is an intimidating list. There's preeclampsia, eclampsia, maternal hemorrhage, cord prolapses, malpresentation, shoulder dystocia, fetal distress. In some cases, like, what is dystocia? I don't remember what these words mean. Eclampsia versus preeclampsia. And we use, in medicine always, ridiculously complicated vocabulary. For example, not on the list, but a nuchal cord. That's the thingy around the neck. It's, the cords around the neck. I don't know why we have to make it more complicated. And then talk about fetal distress. What about the paramedic distress? Or the ER doctor distress? The thing is, this is what we worry about. This is, what makes our heart race when we hear that there's a woman in labor. But you also have to remember, this is generally the outcome. Nice, healthy, happy baby. Generally not that clean to start with, but kind of why are we scared of this? But we're scared about not getting that. Some interesting statistics on pregnancy in the United States. Clearly, it's going to be different in other countries, but out of hospital deliveries only occur in 1% overall of deliveries, and 65% of those occur in residencies. So those are the kind of things that are often going to involve EMS. Some don't. And then 27% are in birthing centers. I'm kind of surprised by those numbers. I'd almost expect them to be the other way around. The overall mortality in pregnancy is 6.2 patients per 1,000. the mortality for when babies are born in the emergency department, and I believe this counts the patients brought in by EMS, is 8 to 10%. Now, why is that so high? Is it because we all have the face kind of like Dr. Ross here, or is it because of something else? Well, one part of it is that nobody plans on having their baby in the emergency department. So a lot of times these are patients without prenatal care, or the classic story here about the patient that denies being pregnant and then has a baby in the emergency department. They also are delivered because of an unanticipated complication. Early unplanned deliveries are what you see in the ER. Again, nobody makes an appointment for that. And then also look at, out-of-hospital deliveries are 1%. We're spending all this time on 1% of deliveries, which is going to be, a low percentage of what you see on a daily basis. Again, this is because we worry about the bad outcomes. We worry about things that happen to the 1%. And so that's, that's why we're here. That's why we're talking about it. And I think that's important. Talking about assessment, sexual activity is often not asked. Now, clearly, if somebody is 36 weeks pregnant, you probably don't need to ask about sexual activity. But the problem is somebody that's not that far along and somebody that either due to the clothes they're wearing or the body habitus, it may be hard to tell if they're pregnant. This is the last thing you want to be surprised with. You don't want to deliver somebody to the emergency department with belly pain and, I think, she's probably got a UTI, and turns out she's got a interuterine pregnancy. And so it's important to ask this. You will, if you ask it routinely, you will occasionally be surprised. There's also some interesting statistics. One study said that 10% of patients in the emergency department who insist that they're not pregnant will be pregnant on that visit. To be honest, I oftentimes don't ask about sexual activity in the emergency department, but part of that's because I am not necessarily going to believe the answer. I pretty religiously test for pregnancy, even when it seems out of the question, and sometimes I'm surprised. And occasionally, you can pick up a weird kind of cancer or give a positive pregnancy test, so you can get that by accident. Also realize patients sometimes come in that will state that they are homosexual and actually be pregnant. So, sometimes situations where it doesn't seem, again, like that 10% who insist they couldn't be pregnant, they can be. A lot of times they say they couldn't be pregnant because they don't want to think about the possibility that they could be pregnant. It's out of the realm of what they want to imagine. There's also a statistic saying that 10% of adolescents in the ER with possible pregnancy type symptoms will be pregnant. Interestingly enough, 10% of those will still deny it even when there is a positive pregnancy test. It's best, as a general rule, if you're going to be asking this more often, to ask in private about sexual activity, especially with adolescents. If their parents are there, the odds of you getting a correct answer are pretty slim. There can also be issues, with multiple partners. You can have a patient who's pregnant, but husband has been gone or has a vasectomy or whatever, and there's no reason to get into that. That's why I always test. In the ambulance, you don't have the option of testing, but it's good to ask, and it does help. Narrow things down. So it's worth asking. Again, we're still going to test, but it keeps you from being surprised. So who is the youngest recorded pregnancy ever? And this is shocking. This was on May 14th in 1939, and that the young lady there gave birth to the baby there in the stroller. That's the doctor standing next door. And her age at the time of birth was 5 years, 7 months, and 21 days. Baby was delivered via cesarean section. This patient had begun regular menstruation at age 3. This was written up in medical journals. The father was never identified. That's kind of spooky. But again, back in 1939, they really didn't have the genetic abilities that we do today to do that sort of thing. Interestingly enough, she had her second child at age 38. So the brothers were 33 years apart. Her first child was raised as her brother until he was older, and then was told the truth. So anyway, I think we talk about the age. Should we be asking a 13-year-old if they're sexually active? Yeah, you probably should. And again, that would be one of those in private, and it gets to be a harder question to ask, especially if you have children. Because you don't think about those possibilities with your own children. I know I have a 13-year-old, and I tend to forget to think about that in children around her age. Focused history. Now, this is a mnemonic that I made up, so don't call in with we've got a 28-year-old patient, 26 weeks pregnant with a negative comb history. Nobody's going to know what you're talking about. But these are things though that are important. Contractions. Are they having contractions? Or they have, and go ahead if it may not be real contractions, but they have something that they think are contractions or that you think are contractions. What's the onset, the frequency? How long do they last? That's all important. Occupant, fetal movement. That's pretty important. Do they feel the baby moving? If it's early in pregnancy, have they felt the baby moving before? Is there anything different? Have they done kick counts and that sort of thing? Is there a change in movement of the baby? Membranes, have they ruptured their membranes as their water broke? That's clearly an important thing. And then, is there any vaginal bleeding? If there is bleeding, is it similar to, greater than, or less than their menstrual periods? And have they had any other bleeding during this pregnancy? So more on the obstetrical history. And this is always hard to remember. Again, it's one of these things where medicine has made things more complicated than it has to be. So gravity is the number of pregnancies, gravida number. And I think gravida, gravity. When you're pregnant, you realize kind of the gravity of the situation. Good or bad, it's a life-changing event. And so, number of times you've had that life-changing event, number of times you've felt that gravity. Para is easy. Number of times you've been a parent. So that's number of live births. Complications. Any complications with this pregnancy? Complications with past pregnancy, and lumped in with that, prior precipitous deliveries. If you have a patient and she's this is her 5th pregnancy and she's delivered all of them in an ambulance, that's probably pretty good to know, versus this is her 5th pregnancy and she's had to be induced every time. I'd be a little more concerned about the first one there. And complications, if somebody comes in with vaginal bleeding at 10 weeks, this is their 5th pregnancy, and they've lost 4 between 8 and 12 weeks, that's concerning. If they have multiple pregnancies and complications in some, the timeline there is important. Did they have, they've had 4 pregnancies and then complications with the first 2 or the last 2? That's good information to have, especially if it's something that may have changed. And then the due date, you want to know how that was determined. The most accurate method is an ultrasound performed around 12 weeks. And so that's the best way to know. But it can, if it's off the due date, if it's off the ultrasound, or if it's off, the last menstrual period, it's good to know. Generally, in early pregnancy, it'll be off the last menstrual period because they will have not had an ultrasound yet. Physiologic changes with pregnancy. I remember trying to remember this, and the heart rate goes up, the blood pressure drops, and all this. And it's kind of like shock. But if you look at the change, the heart rate's 10 to 15 beats above baseline. The pressure drops 6 to 10 millimeters. You can see changes like that on a normal patient during your transport. the pressure changes a little bit. It's a dynamic process. So I wouldn't get too excited about this. Their plasma volume increases. So sometimes they can lose blood before showing systemic effects is the general idea there that you should realize. So if you think the patient's bleeding a lot, but they're really not showing shock vital signs, they may be bleeding a lot. Pregnancy tests. So they detect, the urine pregnancy test will detect 95% of pregnancies within 3 days of a missed period. That's pretty quick. And again, that's, you can only go by that. Somebody is, clock-like regular in their menstrual cycle. A lot of times patients aren't testing that quickly. And if it's later, it's a little more accurate. A negative test at 7 days essentially excludes pregnancy. It's interesting, because patients have a positive pregnancy test and then want to come to the ER and get a test. And, our test isn't very much different than the test they do. Some patients, will claim that the urine pregnancy test doesn't work for any women in my family. I don't really know where that comes from. And then if somebody has had a pregnancy, completed pregnancy or had a loss, you can still have a positive pregnancy test easily for up to 60 days before it will return to zero, and realize that the home pregnancy test with the plus or minus or whatever brand you use, they detect very low levels, so they will be positive for a while. So unfortunately, you can get kind of a false sense. A patient loses a pregnancy and then is pregnant again within 2 months, and maybe 45 days later takes a pregnancy test and it's positive, and they think it's a new pregnancy, and that's clearly a sad situation. Okay, true labor versus false labor. So kind of had to throw this little dig in here. So the old EMS stretchers, you had to actually physically lift the patients up, carry the stretchers, all that kind of stuff. Especially if you had to lower it all the way to the ground and pick them back up. That was true labor, versus today, a little bit of false labor with those stretchers. You got the DeWalt batteries that do all the work for you. Pretty sweet deal. May have extended my EMS career if I'd had something that fancy. But back to the lecture. True labor. Generally, this is pretty obvious. Patients are having contractions that progress in frequency and intensity. A lot of times you can tell when they're having the contraction. They may be talking to you and kind of stop mid-sentence. Granted, some patients are more stoic than others. The contractions generally begin in the fundus in the upper abdomen, radiate into the pelvis and the lower back. And one of the definitions is they cause cervical dilation. This is not something you're going to check, but somebody could be in labor for a while and could have seen their doctor that morning and say that there have been some cervical changes. So it's good to know. False labor, also known as Braxton Hicks contractions. There's no progression. They're not as organized. They're not on a regular schedule. Generally in the lower abdomen. Now with that, I've also found, trying to differentiate with the patient, is it in the upper abdomen, is the lower abdomen, kind of hard to sort out. Part of that is one of the first things they tell us in medical school is the patient didn't read the book. And so that, meaning that they're not going to follow the rules. So if a patient's telling you it's upper abdomen, it could still be a false labor. And so that's, important to know. Now I have seen, I say that generally you can tell, you look in a patient is clearly in a lot of distress, clearly a lot going on. That's true labor, versus somebody that's just sitting there and says, oh, there was a little contraction, is false labor. It's not always the case, and you can get snake bit by that. A patient actually, when I was going through paramedic school years ago and doing my obstetric rotation, a woman who, this was, I believe, her third pregnancy, and she kind of said ooh once and delivered the baby. And so patients with multiple babies can not be as dramatic in their deliveries and kind of surprise you. And it can occasionally happen on a first baby too. So those are general guidelines, but not set in stone by any means at all. Leopold maneuvers. You might hear about this, and guessing this is kind of an interesting slide. So Leopold maneuvers, this is where you're pushing on mom's belly to feel the underlying baby and trying to figure out if the baby is head down, butt up like we'd like, or head up, which way they're facing, or if they're back down. I heard this when I was going through my training. It was explained to me as feeling the knobs. And so basically with one hand you can feel the back, it's a big smooth surface, and then the extremities kind of feel like little knobs on the other side. And so you can figure out, where the back is on one side or the other. And in theory, feeling the head, in practice, especially if you don't do it on a regular basis, that can be difficult. Especially, you may be able to figure out the back. It can be a little more difficult finding the extremities. And then, unless they're with their back on bottom, you really don't know if head is up or down, which is kind of the big thing you want to know. And that can be difficult if you don't have experience in doing that. So I kind of say, and I'm sure this is going to offend obstetricians and midwives, but that Leopold maneuvers are kind of like Santa Claus. It's a great idea, but not that practical in real life. It's practical for them. It's practical for people that do it all the time. For those of us that sometimes play the role of an obstetrician, ER doctors and pre-hospital providers, it's a lot harder to do. If you want to do some clinicals and get better at it, more power to you. Gestational age can be difficult to determine. There's the Nagel rule, which is last menstrual period plus 9 months, then add 7 days. You're going to have to get out a 4x4 package and do your math on that. The fundal height, this is generally what most people use, and it's the distance in centimeters from the symphysis pubis to the top of the uterus, or the fundus there. And distance in centimeters equals weeks gestation. General guideline is that the belly button is 20 centimeters or 20 weeks. So that gives you kind of an idea if we're, as far as viability, if we're getting to the viable ages. Problem is that can be off by 2 weeks. So that's not very accurate, especially, if you're, well, it's okay, it's at the belly button. Is that 22 weeks? Is that 18 weeks? And so it's amazing how non-exact we are in this science. Third trimester ultrasounds can be off by 3 weeks. So really, kind of dating is, can be voodoo to an extent. Again, though, a 12-week ultrasound is the best, and that's the most accurate. And a lot of times when a patient is dated from a 12-week ultrasound, if they get different dates, maybe on a third trimester ultrasound, they generally won't change the due date at that point. The best thing with this, it's a good idea to have a ballpark figure. And what I do, I look at the fundal height, get a general idea, and then I use an app on my phone, either off the due date they've been given, which I generally like to do that because that's really from their 12-week ultrasound. And so that's going to be my most accurate, and I'll determine where they are. And I like to confirm that the due date I get from the app is or the age, the gestational age I get from the app is consistent with what I'm getting from the fundal height. Okay, confirmation of membrane rupture. So if a woman is leaking fluids, sometimes that, to be honest, that can be urine, or it could be rupture of membranes. There's we talk about nitrazine positive. That's a pH paper that you dip in the fluid, and if it changes a certain color, then this is most likely amniotic fluid. There's also ferning, which is kind of interesting. That's kind of why we're talking about it, because it's kind of cool. You take a sample of the fluid and put it on a slide, and when it dries, it makes this crystal kind of pattern known as ferning. Really, I understand this is not something you're going to do in the field with that, but if you pick somebody up at a doctor's office or at a birthing center and they say they got a leakage of fluid, it's positive for ferning, or nitrazine was positive or negative, that tells you some information. I guess you could also, collect the fluid on a 4x4 and smear it on your partner's glasses to see if it burns, but that's probably not the best idea. So really, as a pre-hospital provider, you're not going to be in a position to collect the fluid because that's really done on a speculum exam. So rupture of membranes. Important thing here is the longer elapsed time between the rupture of the membranes or the leakage of fluid and delivery is the greater risk of significant infection. So when the baby is in their sac, they're protected. It's a sterile enclosed environment. As soon as that starts leaking, it's open, and so it's a route of infection, and it can be a serious infection. A lot of times for mom, more often, but also for the baby. And so sometimes these patients are managed long term in the hospital. They're in the hospital for a long time with medications to keep them from going into labor. As a general rule, 50% of women will deliver within 5 hours of rupture membranes. 95% deliver within 28 hours. So, looked at that. So you got 45% are going to be between 5 and 28 hours. That's why, there used to be guidelines that would say, if they've ruptured or if the, contractions are so far apart or whatever, that you stay on scene and deliver. Probably not going to work out if you stay on scene for 28 hours. I guess you could have shift change in their living room, but not a real practical plan. Stages of labor. So this is a pregnant lady on stage. There are 3 to 4 stages, kind of depending on what book you read, which again is kind of strange that even that's not agreed upon. Stage 1 is cervical preparation, not to be confused with conception, but this is cervical dilation and that sort of thing. Stage 2 is delivery of the infant. Stage 3 is delivery of the placenta. And stage 4 is uterine contraction. We're going to go over this in detail here in a second. One thing, too, is we generally, after stage 2, infant of the delivery, a lot of times that's when we're doing high fives and touchdown dances and stuff. And forget, we're only halfway through the stages at that point, and you need to keep paying attention to what we're doing. Stage 1, cervical dilation. This can last 5 to 8 hours. It can last, and this is a typical duration. Clearly, it can last longer than that. During the latent phase of this, contractions are irregular and frequent. And again, so based on that could be confused for a false labor. And so really, pre-hospital environment, you're not going to be able to make that determination because a lot of this is going to be based on there are changes in the cervix occurring during this period. And patients may be sent home during latent phase 1. Active phase generally starts at 3 to 4 centimeters dilation. Dilation progresses at 1.2 to 1.5 centimeters per hour. Patient says, I was at 3 centimeters. My doctor sent me home. That was 8 hours ago. You don't need to do the math to figure out how dilated that they may be at this point. Stage 2, delivery of the infant. It's interesting. It's referred to as fetal expulsion, which doesn't sound like a good thing, but it is most of the time. So on average, this is 20 to 50 minutes. There's an urge to bear down. And again, sometimes the urge to bear down is wishful thinking. But as a general rule, I would take it seriously. Contractions last 1 to 2 minutes with a rest period of 1 minute in between. And again, remember, every number here is kind of a guesstimate. Some women will deliver much faster than that. And this is the, I guess, most safe for work picture we could find on the internet of Octomom. Prolonged second stage of labor. And these numbers clearly don't need to remember them. 3 hours if it's our first baby with anesthesia. If they're on labor that long in the second stage, that's considered prolonged. 2 hours if there's no anesthesia or if they've had babies before. And then 1 hour if they've had babies before and there's no anesthesia. Clearly, you're not giving epidurals out in the field. But what matters, so 1 hour in a patient that's had babies before without anesthesia. So that's that number matters to you because that means this can happen fast. Woman, this is her 5th baby. She's at home and she's been in labor for 30 minutes. Pretty good chance you're going to deliver that baby. So that's something. But versus if you have, first pregnancy, been in labor for 30 minutes, less likely that you're going to deliver that baby. Stage 3, the pizza delivery, known as placental expulsion, generally occurs within 10 minutes. And again, keeping with the pizza analogy, need a little more active management if it's not delivered within 30 minutes. And then don't roll the dice. Okay, you got to forgive me. I'm going to do an Andrew Dice Clay impersonation here. He used to have a poem as part of his act. Said, "There was an old lady that lived in a shoe. She had so many children her uterus fell out." Don't roll the dice. Don't make anybody's uterus fall out. So what I mean by that, don't yank on the cord. Don't get too excited about that. Then stage 4 is back to normal. Uterus is contracting down. Placenta's already delivered. Uterus is contracting down. Everybody's happy and things are going well. So we're going to talk a little bit about kind of going over this in a little bit more detail. Back to stage 2. So this is kind of where the rubber hits the road. This is the part that we either worry about or are excited about. And you got to fake it. This may be mom's first baby. You need to at least act like it's not yours. You need to, and that's, and y'all know that. That's a big part of EMS, is no matter what's going on around you, you need to act like, hey, this is a cakewalk. I've done this 100 times. You need to be calm and in control no matter what's going on. You also need to prepare the area, yours and hers. You need to make sure you have, what you hope is going to happen. You need to make sure you have things to deal with cutting the cord. So just ripping open the OB kit and knowing that, there's something in there. You need to know what's in there and have it out and ready, readily available, because you may need it at a moment's notice in some cases. And you need to, get out, chucks if you have them under mom. You need to get mom positioned where you want her. You need to make sure you have people around to help, because really, you have one patient, you're about to have 2. And you need to have, a second set of hands to help managing both. I guess, if you watch TV and the movies, somebody needs to boil water. I'm not sure what you're supposed to do with that. I think generally that's a good rule. If you're delivering a baby at home and dad is obnoxious and in the way and knocking you out of the way trying to film it, you could send him to boil water, and or any person on scene that's not real helpful. The other thing too is people forget, in addition to delivering a baby, you're going to deliver a placenta, and what are you going to do with that? So you need to have your basin or whatever the placenta is going to go in. You need to have that prepared because you don't want to think about it as it's coming out. And again, all that, having things ready when you need them, that adds to that sense of professionalism. It's going to make it go better for you. It's going to make you look better. It's going to make it a better experience for mommy and baby. So look out, world, here I come. This is where the party gets started. So this is when the baby is starting to engage. They come down, the head engages the cervix is dilated, and the neck flexes and they extend. Then there's some internal rotation. So you look back in the last slide, baby was facing this way, now they're facing down. There's a little bit of internal rotation. And then this is where, they've rotated internally. Head starts to come out. Now there's extension of the head, delivery of the head. This is when you want to check the neck for a nuchal cord, and you need to address this if found. We'll talk about that here in a minute. Then there is external rotation. The baby has turned, rotating so that the baby's shoulders are perpendicular to the mom's. This is best for delivery. If you care about remembering this, how the baby was facing a minute ago and how they're facing now, you think about what they're gonna, where their face is gonna be when they come out. It makes sense that they would rotate to get away from that. Not a good, pleasant first view of the world. And so that they will rotate. Now, with that, there's all kinds of variations. Do they rotate to the right? Do they rotate to the left? Sometimes, again, the baby definitely didn't read the book. I've seen babies that they start to come out, and then they just spin, like a kind of corkscrew out. And so that can happen too. So I wouldn't worry if the baby spun one way versus the other or whatever. But again, we're just talking about what's normal, and you got to understand that first. Delivery of the shoulders. Generally, it's the anterior, the top shoulder, that comes out first. That comes out, and you're bringing the baby downward. And then to deliver the posterior shoulder, you kind of bring the baby up. Now, it's really important to understand that we're not pulling, we're not tugging with that. Almost that picture kind of looks like we're yanking the baby by the head. That'd be a bad plan. So we're going to go through a demonstration of a normal delivery. The scenario that we're jumping into now is a woman that is in labor at term. Her water is broke. She's having regular contractions, and we're going to need to go ahead and stop and deliver the baby. We're looking, we can see a little bit of crowning as the baby comes down. We can just gently part here. We can see the dilated and thin cervix and the crowning the head and the fontanelle. We talked about in the presentation, you can palpate the fontanelle to get an idea which way the baby is presenting. We'll just give a gentle assistance with the cervix and the labia as the head comes out. At this point, if there's meconium staining, you want to try to speed things up, deliver the baby without stimulation so it can do tracheal suctioning. Otherwise, we can continue to move on, and we'll deliver the anterior shoulder by going downward. And then the posterior shoulder by coming upward. I'm going to support the baby, holding like a football. The baby out. We can clamp the cord. At this point in time, we could cut the cord, get the baby wrapped in a towel, hand it off to our partner for suctioning and stimulation at that point. And then we want to stay and deliver the placenta. We don't want to tug on the cord because we don't want to cause it to tear off prematurely, and we don't want to invert the uterus. This can take 10, 30 minutes to deliver. As it delivers, there'll often be a gush of fluid and blood, and that's fine. We'll stimulate the placenta delivering here. Generally, we wouldn't need to reach in to deliver the placenta, but in this case we do. It generally comes out very gently on its own, and comes out. You do want to inspect, make sure it looks like it is intact, and that's pretty. There's no trick to that. That's kind of a gross observation. You're going to package that, deliver that to the hospital for full inspection also. And then at that point is when you would start uterine massage, just pushing down to help the uterus contract, and that'll allow things to dampen out any bleeding and slow that down. And then bring the baby back to mom, and they can start the bonding experience at that point. And that's basically a normal delivery. And so now we're going to go back again and talk about this in a little more detail because that was kind of quick. And so on here, so as the baby's crowning, the head is coming out, they haven't rotated yet. This is where you need to take control of the infant. You're an active participant, not a spectator here, and that's important. We get too many spectators. and not enough active participants. So you also need to support the perineum, the mom's tissue around here, because we don't want her to tear. That can be a big problem lifelong. And so generally a sterile towel, that's what the towels are there for in the OB kit. You can put that down on the perineum. That can provide a uniform support. You see with that bottom hand there. And it also helps get a grip. I mean, again, everything is wet and slippery. And the baby's going to kind of come out onto that towel. You want to have gentle counter pressure on the head. So you're kind of have pressure going back towards mom because you don't want everything to come out too fast. Again, more likely to have tears with that, more likely to have problems with a rapid delivery. Risk of complication goes up significantly at that point. And so you want it to be slow and in control. Tears, in addition to being very uncomfortable, taking a long time to heal, if mom tears in delivery, that there can be tears that go all the way through to the rectum that cause problems with incontinence for the rest of her life of both bowel and bladder. So a tear can be a life-changing event, and it'd be a shame if we didn't do everything we could to prevent that. Sometimes you can't. I mean, sometimes it's going to happen, but we need to at least feel comfortable that we're doing what we can to keep it from happening like that. And then, so baby coming out. So you've got your bottom hand that was supporting the perineum with the towel. It kind of comes up now at this point and is supporting the chin. And this is actually, kind of a natural. As more comes out, you reach up and get a better grip. At this point, we want to slow down. Tell mom stop pushing and breathe through the contractions. This is ideally where the baby's going to turn and line up the shoulders. This is where you want to check for a nuchal cord. That's going to be in 25 to 35% of all deliveries are going to have a nuchal cord. And remember, that is where at this point the umbilical cord is wrapped around the baby's neck. And so you want to figure that out there or at this point and address it. And so most nuchal cords can be easily reduced. You've got the head out, you see the cord there, you just slide a finger under the cord and it can generally gently lift that up and around the head to free that. And that's what happens most of the case. If it can't be reduced, you need to clamp it and cut it right there because you don't want it to tear. And so this is why I said you want to have those clamps ready. Cutting the cord is, a lot of times you think, oh, well, that's, after the baby's delivered, things have calmed down, then I can find the clamps. But if you need to do it right now, you need to do it right now. And so you need to have all that available. And again, inattention to these details can easily turn something that would have been nice and easy into a nightmare. And you'll never know. If you deal with a nuchal cord appropriately, you'll never realize that it could have been a disaster. It's also important to realize that, you see the cord around the neck and you think, oh no, the patient's choking. It's not an airway issue. The baby doesn't have an airway at this point. There's no air. It's a circulation issue. The cord wrapped around the neck is, a lot of times, especially during delivery, or before, is getting compressed, and so it's not delivering blood to the baby or from the baby. And so they're becoming hypoxic because they're not getting blood delivery, but it has nothing to do with their airway. So that, can be an issue if somebody's stuck. It's also, in this scenario, you're worried about it tearing and causing issue. It's a circulatory issue when they're still in utero. But it's, here we worry about it tearing and becoming a blood loss issue for both mom and baby. Okay, so now we're going to talk about what to do if you're presenting with a nuchal cord. And nuchal cord, fancy way of the umbilical cord, is around the neck. And this happens in more than 10% of births. It's not unusual. What you want to do is make sure you identify it and address it quickly. So as soon as it gets to where you have access to the neck, you want to look for the nuchal cord. It's obvious in this scenario. We generally identify a little sooner. Most of the time what we can do is just slide a finger underneath and reduce the cord like that pretty easily. You don't want to put a lot of tension on there. In this scenario, though, we want to talk about what works when it's not that easy. And so if we can't slide the cord over, we want to go ahead and clamp it and cut it. And so that would just be your standard 2 clamps, cut the cord, and deliver as you would normally. But again, the important thing is to identify and address this early in the process. Anterior shoulder delivery. Again, the anterior one generally comes out first. It's, if it needs a little help, it's gentle. They say gentle downward traction. Really, this is more support than pulling. You really shouldn't pull. Pulling, if that shoulder's stuck, if you look at that picture, you can see how pulling that shoulder down is going to stretch the tissues from the shoulder to the neck there. And your brachial plexus runs through there, which provides all the important nerves to the arm. And so there's specific injuries that you get where pretty much use of that arm is lost from a birth injury here with somebody tugging on the head trying to get that shoulder out. And so that can be an issue there. Once the first shoulder, the anterior shoulders come out, then you support the baby and come upward gently, and that delivers the posterior shoulder. Again, you still have to maintain control to avoid mom having any tearing. And it's important that you just stop and you think about it. If you're delivering the baby and the head's out and they're not really progressing, slide your fingers in there and see, which shoulder is coming out. And so do I need to be reaching in, kind of helping go up or down, and just think about what's going on in the mechanics behind it, and it becomes pretty easy. Now we're going to review shoulder dystocia. So this is when the head has delivered and the baby is stuck at the shoulders. The first thing to do is a McRoberts positioning, and that's where both the legs come up. You'll need generally you need a partner to do this. You can bring both legs up toward the chest, run a sheet underneath the knees, and have somebody pull up from the head. That helps tilt the pelvis and open up the pelvic outlet a little bit to facilitate this delivery, and that works the majority of the time. If that doesn't work, then we need to do what's called a reverse wood screw maneuver, and so that would be at this point in time, with my bottom hand, I'm feeling the posterior shoulder with my fingers inserted up to the shoulder, and then we're going to twist toward my right and deliver the posterior shoulder, and then that's going to bring down the anterior shoulder also and deliver just like this, supporting the baby's head and delivering like that. Now we're going to go over breech presentations, and this is generally what we tend to be most scared of. It's important to remember that in most breech presentations, the baby will deliver on its own without a lot of assistance. We're going to talk about what to do when we have to provide assistance. And so this is a frank breech where basically the bottom is presenting in this scenario. And so if the baby's not progressing normally, we would come in, you rotate the thigh, a little external hip rotation, and rotate the hips in the opposite direction. So I'm bringing the thigh that way and the hips this way, and we come down. As we get down, we can deliver the legs. They'll rotate out to the sides. We get down past the umbilicus and should be able to reach up and deliver the arms. And generally at this point, head will generally come out pretty easily. One thing to remember is that oftentimes the reason for the breech is that these babies are small, they're premature, they're small for gestational age, and so they're less likely to get stuck at the head. But they can, and if they get stuck like that, at this point, like I said, give them a chance to come out. If they don't, then you can grab the legs, supporting the head. You can come up like this, and so at this point we've got airway access. and then deliver the baby like this. Clearly, you want to be careful about too much traction and torsion this way, but you have to remember, the big part of the head is the occiput here, and so what we're doing is just rotating that way to bring it out, and that should help facilitate that delivery. You can also sometimes, if you need some suprapubic pressure in this maneuver or in the shoulder dystocia that we talked about earlier, can help facilitate that. And then again, clamp the cord and do everything else as we would normally. Easier. Don't drop it. That's clearly the important thing. You look in the hospital, they have, when they deliver babies, you do your obstetrics rotations, and mom's bottom is right up on the edge of the bed, feet up in stirrups, and so the baby's coming out a lot of times, looks like over air. You want to deliver the baby onto a bed. If they're on the stretcher, you don't need their bottom on the edge of the stretcher. You want them in the middle so that the baby comes out onto the stretcher. Baby's going to be slippery. And so you don't want to set yourself up to be in a position where you can drop the baby by any means. They talk about when you deliver the baby, then holding the baby like a football. Not exactly the way Tim Tebow's doing it, but general idea. So that would be one reason to gown up. A lot of times think, pre-hospital providers, I know when I was a medic, I don't know, I felt like I didn't need gowns a lot of times, but here you're going to hold this wet, messy baby up against your body to keep from dropping it. So it's a good time to put on a gown. Generally, you want to have them head down to help with clearing secretions. Then you want to get the baby cleaned up, warm, and dry. Get them wrapped up pretty quickly and cleaned up. And it's very easy for them to have a lot of heat loss and become hypothermic very quickly. You think about what it's like, when you get out of a bathtub or a hot shower and it's cold. It's like that, but magnified exponentially for the babies. Cutting the cord. So there's all this. So 3 centimeters from the baby, put 2 clamps down. You want to, if you've got something you can clean the cord with, probably do that. A lot of times they don't in hospital, but pre-hospital it's considered a dirty delivery. Don't worry about 3 centimeters. I would err on the side of long. You can hear L&D nurses will always say that they can tell which babies were delivered, not in L&D, like, in the ER or pre-hospital, because they have a tail, because the cord is cut long. It's better to leave a long cord than a short cord, so if you're going to make a mistake, that's the way to do it. And then, you can offer, to let mom or dad cut the cord. I know the babies I delivered pre-hospital, the OB kits that we had, they didn't have scissors, they had a scalpel. And, you hand dad the scalpel to cut the cord, and sometimes that makes them a little queasy. It's a little more barbaric than what they anticipated, what they were shown in the birthing videos. And there's probably going to be blood squirting with that too, so be prepared for that. So what about that bulb thing? You were always told about bulb suction. You got to suction the baby out. Stop, suction the baby. And so, it used to be that as soon as the head comes out, you have to suction. And that actually dropped out of the guidelines in 2006. It's still what a lot of people believe, but that was taken out of the resuscitation guidelines, 8 years ago, but it's still commonly believed. When you do suction, it is the mouth first and then the nose. I always had a hard time remembering that, but if you think about it, it's kind of gross to stick it up their nose first and then put it in their mouth. So that's one way to remember it, which is the least disgusting. You're doing it because you want to clear the mouth because you don't want to have a mouth full of meconium and stimulate them breathing by suctioning the nose first. So that's a concern. But so here's that guideline I talked about that changed quite a while ago. So and what we're worried about is meconium aspiration. And so the guideline, is meconium present? No. If it's not, just continue with the remainder of steps. Deliver the baby, clear him, stimulate, repeat. If there is meconium, is the baby vigorous? So does the baby look good? Yes. Leave him alone. Do it like a normal delivery. If they don't, if the baby's not vigorous, the baby's limp, there's concerns, then what they want you to do is limit stimulation, get the baby out, and just go ahead and do tracheal and oral suction together. Get it all out at once with that. So that's the guideline. That's out of the current neonatal resuscitation textbook. So that is, if they're meconium staining and they look sick, just get them out and get them on a blanket and get your laryngoscope out. If you're not a paramedic level provider, do the best suctioning you can at that point. And then delivery of the placenta, generally, like I said before, occurs between 10 and 30 minutes. Gentle traction, if any traction. I mean, you can pull a little bit. Again, you don't want to invert the uterus. The uterus can actually pop out if you pull on it. And that can be a problem also. Or you pull on it, you could tear the cord from the placenta. You could tear off part of the placenta. All this can result in severe vaginal bleeding. So there's no reason to be in a big hurry with this, because you can create a problem. Massage the uterus. I was thinking, we say massage the uterus, and that really sounds kinder and gentler than what we're talking about. It's more like a punch in the gut than a massage. Not that you're punching anybody, but deep massaging of the abdomen. It's not going to feel good. It's uncomfortable to mom, but it makes the uterus contract. The uterus contracts, and the bleeding from where the placenta had been will tampen that off and slow down, and that's the important part to stopping the bleeding. So, we say massage the uterus, and that sounds real nice and touchy-feely. Candles and aromatherapy, but that's not at all what we're talking about here. And then at this point, congratulations, here's the baby. Everything's good. Everything's wonderful. This is what we've got, and this is what we're good for. People are high-fiving. You're carrying the baby like a football. Don't get excited and spike the football. That's clearly a bad plan. But don't forget mom. Sometimes we can be all excited and the baby, look, the baby's great. The baby came out great. And mom is having some problems. And mom may be so elated about the birth that she's not really picking things up. What you don't want to do is, you've got the baby, everything's great, everything's wonderful, delivered him in the back of your ambulance. You pull out the stretcher, and underneath the stretcher, you had mom covered up for privacy with sheets and stuff, and you pull the stretcher out, and there's just this huge puddle of blood that you had no idea that mom was still having some bleeding. And so don't forget about her. This is really a scenario where you really want two providers, one focusing entirely on mom, one focusing entirely on the baby once it's delivered. And you keep it like that. Even when the baby's delivered, somebody's by mom's side talking to her. Now, hopefully, you've got mom holding the baby and they're geographically together, so that's a little bit easier to do. So this is a review of normal birth and how things should normally go. We're going to go ahead and get started here in a second with the problems that can occur during. Now, for the second part of this presentation, we're going to talk about when pregnancy goes wrong. We've talked about the normal birth and what to expect, and now we're going to talk about the things that cause us all to make that George Clooney, Dr. Ross face, and when pregnancy goes wrong, and the things that we're all scared and worried about. Now, it's important to remember that no matter what you do, there will be some bad outcomes in pregnancy that we can't avoid. Now, I don't know if Justin Bieber was born pre-hospital, but I'm sure wherever he was born, there was nothing the provider could do to prevent the bad outcomes that have since occurred. So now we're going to move on and talk about what to do with the prolapse cord. And so that's when the umbilical cord has come out of the cervix and is what we're seeing here. The concern is that then as the baby comes through, the umbilical cord is going to get compressed and cause issues clearly with circulation. At this point, generally, what is going to happen is the patient's going to need a C-section. We need to kind of stop and circle the wagons, preserve what we have here. And so what we want to do is keep pressure off the cord. And so you'll insert a gloved hand, generally 2 fingers, into the vagina to where you can feel the presenting part, maybe the head, could be a leg or an arm, or the buttocks, and lift that off of the cord. A lot of times also they talk about a knee-chest position, so that would be with the patient prone position, then knees up to her chest or bottoms up in the air. And so gravity is bringing some of the pressure off of the cord. That's hard to do and transport a patient safely in the back of an ambulance. Even if I was doing that, I would still want to insert my fingers so that I can feel that I've got pressure off of it. Be careful not to put pressure on the cord itself. One, clearly that's counterproductive, and number 2, that the cord can spasm, and even, so just touching the cord can cause a spasm, and then when you relieve the pressure, you're not getting the benefit that you would cause of that spasm. And so this is what they talk about, where once you do this, you're pretty much going to follow the patient to the operating room for the C-section with this. But it's just whatever you can do to relieve the pressure off of the cord, and then that'll buy time to get a C-section team together. Things we're going to talk about as far as the emergencies at this point. Going to talk about bleeding in early pregnancy, hypertension in pregnancy, preeclampsia and eclampsia. I'm going to give a little case scenario about peripartum cardiomyopathy. Not a lot of information about that, but it's pretty scary. And then the Kama Sutra. I made that up. I figure the Kama Sutra is how the baby got there. The Kama Sutra is how they're getting out. And so we'll talk about the complications associated with the Kama Sutra. An anatomical review, we really don't need to get into this a whole lot, but I'm kind of want you to see what the chorion is. You see there over on the left-hand side, about midway down, it's part of the amniotic sac there. It's one of the layers there. So we'll talk about when we talk about the chorion. Then there's the placenta and the baby and the cord, and all the stuff that we understand and learned in probably middle school. Statistics. Up to 30% of pregnancies result in early loss. I've even seen statistics quoted as higher than that. 80% of the losses are in the first trimester, and 25% of women experience bleeding and spotting in early pregnancy. Generally, early pregnancy losses are due to catastrophic genetic abnormalities. Chromosomes just didn't line up right. And to be honest, when you really drill down and learn about the chromosome movement and everything, it's amazing that it ever works. When I was learning that in undergrad school, my wife was pregnant with our first child, and I came home and told her, I'm sorry, sweetie, there's no way this can work. I mean, it's just magic. And so it's a miracle that it ever works, and it does well. You also need to realize, just something that's kind of surprising is that, so when someone loses a baby, you don't get the high-risk workup for pregnancy loss until you've lost 3 babies. That's the guideline. And that's kind of shocking, because that's 3 losses is a lot to go through before you do that workup. And part of it, sometimes patients, they lose 1 baby, they want to be in the high-risk pregnancy group. The high-risk pregnancy group is a rough group to be in. You're going to get a lot of testing and a lot of ultrasounds, which seems good, but then you're going to get a lot of answers that you don't want to deal with. My wife and I lost a baby due to a nuchal cord. She was 37 weeks and passed away in utero, had a fetal demise. And we were in the high-risk pregnancy group afterwards. There was no reason clinically for it. I was in residency, and it was kind of a courtesy because we were scared to death in the subsequent pregnancy of another loss. And so with that, there were frequent ultrasounds. And I knew that was going to be a problem. And one of the ultrasounds, I believe it was, at 20 weeks, they could see the umbilical cord right up in front of the baby's neck. But they couldn't tell if it went around or if it had just come up and made a loop right there. And so, as you can imagine, we're pretty concerned that this was another nuchal cord. And at that point, there's nothing you can do about it. There's generally nothing you can do about it. And you just have to, cross your fingers and and wait for the next ultrasound. And the next ultrasound, the cord was nowhere near the neck, and that baby's now 6. Everything worked out well. But so you get the high risk workup is a pretty stressful thing to go through. And you're kind of reminded on a regular basis about the vulnerability of everything. Causes of vaginal bleeding in early pregnancy: implantation bleeding, subchorionic hemorrhages, ectopic pregnancy, miscarriages, and embryonic gestation or blighted ovum. These 3 in yellow here in the middle, we're going to talk more about those. Implantation bleeding, this is generally 6 to 12 days after ovulation, fertilization. It's a scant pink discharge or brownish color, and it's not significant. Blighted ovum, again, this is kind of a chromosomal disaster, and you have a gestational sac, so there's enough to kind of get that process started, but not enough to start a baby. So there's an empty sac. And this is the most common cause of a first trimester miscarriage. Subchorionic hemorrhages. So this is, remember that slide we showed a minute ago showing what the chorion was, and so that's part of the background there. So this is bleeding between the chorion and mom, not placental, abruption or anything like that. It's not at the placenta, and so this is 18% of first trimester bleeding. The size and location of this are prognostic. It says that it's worse if the bleeding's at the implantation site. If the bleeding is less than 25% of the gestational area of the sac, then that's a good prognosis. Generally, management is pelvic rest. Like I said, this says 18% of first trimester bleeding. It sure seems like I see that in my patients more frequently than that. It seems like a pretty common cause of bleeding in the emergency department, at least where I practice. Ectopic pregnancy, 2% of all pregnancies. This is the leading cause of first trimester maternal death. Risk factors, common sense things. If they've had an ectopic pregnancy before, they're at risk for another one. If they've had tubal ligation, that's the thing, patients, I can't be pregnant. I had my tubes tied. Well, you can be pregnant, and it's more likely to be a disaster if you are. And so, again, it's not common, it's the exception, but in emergency medicine, we worry about the exceptions. Sexually transmitted diseases, I guess actually it's supposed to be called sexually transmitted infections now. Smoking. Smoking is a risk factor for anything. If you're taking a test and smoking is a risk factor, it's probably the answer, if that's what the question's about. An IUD use risk increases ectopic pregnancy risk. And also, sometimes patients get pregnant with IUDs. Sometimes those can be a disaster. The baby develops around the IUD, and so they end up with like the IUD in their chest or their head, and that's horrible. I saw was in a clinic, and they called all the students in to see if they were doing ultrasound, and there was a baby near term and had the IUD in his hand. Looked like he was playing with it. He had grabbed it, and that was lucky. Everything developed okay. Ruptured versus unruptured. Generally unruptured ectopic, there's abdominal pain and cramping, light bleeding. This could even present as being late for a menstrual cycle, or the patient may not even know they're pregnant and have the potential life-threatening ectopic pregnancy. Once it ruptured, patients a lot of times present as an acute abdomen, and they're in shock. But unfortunately, again, that's what the book says. It's not always the case. Sometimes it's not that impressive because they're compensating well. This picture is actually an interesting thing. This is a heterotopic pregnancy. So there, the bigger circle that says IUP in the label is a normal intrauterine pregnancy. The one to the side there is an ectopic pregnancy, one over to the right. And so this patient has a normal pregnancy and an ectopic pregnancy. And so a lot of times that is the ectopic pregnancy is dealt with via laparoscopy, and they're able to carry the intrauterine pregnancy to term. Heterotopic pregnancy, generally a pretty rare thing in natural conception, it's 1 in 30,000, so it's not a very common thing. Chances of you seeing it are pretty slim. However, if it's an assisted fertility, where they're getting medications so that they release multiple eggs, or it's intrauterine, where they put in a bunch of fertilized eggs and stuff, the rate goes from 1 to 30,000 to 1 in 100. And the thing is, a lot of times we forget to ask if there were any assisted fertility techniques used. And a lot of times I'm surprised how rarely that's volunteered without asking. And so that significantly changes the game if there was some assisting technology used there. Makes ectopic pregnancy a lot more of a risk. Just general knowledge, ultrasound, transvaginal ultrasound generally can see a normal pregnancy at 4.5 to 5,000 weeks, to 5,000, 4.5 to 5.5 weeks. Sorry about that. And what we do generally, we get the hormone level, the beta HCG number, and there's argument about that. But generally, if that's around 2,000, we should see a normal intrauterine pregnancy. Now, if it's lower than that, we still do the ultrasound because we may see abnormal pregnancies with that. So, but there's some argument in the literature about that. That's called the discriminatory zone. And if anyone wants to talk about that, I'll be more than happy to chat with you in the ER sometime. But ectopic pregnancy, this is what ER docs are scared of because easy to miss. Because you get somebody early in the pregnancy and it could be an ectopic pregnancy or it could be a pregnancy that's too early for us to see. And so this is something where close follow-up and repeating hormone levels at 48 hours becomes real important. Miscarriage. It's important, and I try to tell patients this right off the bat when I see somebody that's pregnant, or especially early pregnancy with vaginal bleeding. The best diagnosis that they're going to leave my ER with is threatened miscarriage. That basically means you did not have a miscarriage, but there was bleeding, so you might have a miscarriage. So there's a little bit more of a chance of a miscarriage. And that's the best diagnosis they're going to get. I always tell them that at the start because that's hard to see on a piece of paper. Because I come in and say, hey, everything looks good, and then they discharge with paperwork that says threatened miscarriage. That seems, like two dichotomous positions there, and it's not. That's just the best that they can. And I try to tell them that right off the bat, so it doesn't sound like I'm kind of backtracking later on with that. So I tell them, listen, I haven't examined you. We don't have an ultrasound or anything. I'm telling you, this is what I'm hoping for, that you leave here with the diagnosis of a threatened miscarriage. Because really, to say that I'm hoping you have anything that has the word miscarriage in it, it's kind of hard to swallow. But that's the semantics of it. We can't, once you've had bleeding, you're not going to leave with normal pregnancy. And then, there's all kinds of threatened miscarriage, septic miscarriage, incomplete, inevitable, all that doesn't matter. The semantics of a lot of that are not that important for you. An inevitable miscarriage means the os is open. If the os is open, this pregnancy is not going to be taken to term. And then just couldn't resist a little Wizard of Oz play. Can't believe I hadn't seen this before, but went looking for it today. But the great and powerful os. You can't leave that alone. RhoGAM, I want to talk about this a little bit because there's confusion about it. You're not going to give RhoGAM in the field, but family members are going to ask you about it. It could be part of your life, and patients, and it seems complicated, but it's easy to understand. One, this is why we always want to know mom's blood type. It's good for you to ask mom her blood type. She may or may not know. Even if she does, I'm going to check it. Again, like I've said before, I check everything. I check pregnancy tests on all women of childbearing years, and I'm going to check blood type on everybody that's pregnancy. And so what happens, the concern here, and this is kind of a complicated slide, but the gist of it is, so if mom has a negative blood type, A negative, B negative, O negative, whatever, and dad is positive, so then the baby can be positive, from dad. And if there is any bleeding, then that allows a mixing of fetal and maternal circulation. And so mom can be exposed to fetal blood that is a positive blood type, and she develops antibodies to that. Doesn't cause any problem with this pregnancy. But then the next time she gets pregnant, and say that the next baby has a positive blood type, mom will have antibodies against that, and that will attack the baby and be disastrous and prevent that pregnancy. So there's a medication called Rogam that we give mom if mom has a negative blood type and there's any vaginal bleeding potential for mixing of fetal and maternal blood in mom. And this prevents that from happening. It blocks mom from developing an out-of-body an immune response to it. So it's not. So the Rogam thing is not an issue for the current pregnancy, but it is an issue for all subsequent pregnancies, and that's important to check. And it's good, if you get mom's blood type, and especially when she's negative, that kind of reminds us that, hey, we need to do this, and that's an important thing to do. And some moms will end up getting multiple doses of Rogam throughout their pregnancy. Just to lighten things up, there's not a lot of public presentation appropriate pregnancy-related humor. This was as close as I could come up with. Little puppy there says, "My mom was a tiger and my father was a brave dog." I just thought that was kind of funny. Hypertension in pregnancy, that's a pretty common thing. And it is 1% of pregnancies, but 16% of maternal deaths. That's kind of a surprising number. And it's easy to be kind of complacent. A long time ago, we used to get excited about blood pressures and treat them, give them procardia and stuff like that. And then we kind of have stepped back a little bit, and pressures have to be pretty high for us to treat them emergently in the general public. But we need to have a lower threshold in pregnant patients. And so hypertension in pregnancy causes risk factor for multiple issues. We generally want to treat blood pressures with a systolic of 150 to 160 or a diastolic of 100 to 110. So this is a lot lower than we're generally treating our non-pregnant population with. And it's important to realize that severe gestational hypertension has more perinatal complications than mild preeclampsia. We all worry about preeclampsia and eclampsia, but we don't really worry that much about a blood pressure over 150 over 100, and we probably should be a little more concerned about that. Then preeclampsia. This is a constellation of symptoms related to inflammation. There's a lot of different theories about it. Every organ system in the body can be affected by this. And this is basically gestational hypertension plus proteinuria. The gold standard is a 24-hour urine collection. There's a lot of problems with this. You send the patient home with a jug to collect urine, and they miss one or two samples because they're out somewhere or whatever. But that really destroys the validity of the test at that point in time. So a surrogate is, on the urinalysis, we do a 1+ protein on the urinalysis, is roughly equivalent. In the hospital, they'll do a 24-hour collection, but that's a little bit easier. Again, neither that you're going to do, but if they say they've had protein in their urine, that's what you need to be worried about. Classification of preeclampsia, and it's kind of interesting. Mild. You look at mild classification. So, systolic of less than 160, diastolic of less than 110, absence of other symptoms. Well, so. What that means nothing. So if they have proteinuria and a pressure of 150 over 100, that'd be a mild preeclampsia if there's no other symptoms. So really, proteinuria is going to kind of be the key there. And so they may tell you they've had protein in the urine, and so if they're doing okay, you know that's what's going on. So severe, the higher blood pressure, that proteinuria greater than these numbers, you're not going to know that. Thrombocytopenia, that's a lab, you're not going to know that. Liver function, oliguria, intrauterine growth restriction. None of that is going to be of any use to you as a pre-hospital provider. The changes that are highlighted, however, are cerebral symptoms. They're not acting right. Having a headache. They have vision changes. Right upper quadrant pain can be an issue. Pulmonary edema is an issue. So all these things, they've got the high blood pressure and they're sick. That's a concern. Now, other problem too, right upper quadrant pain. You can have gallbladder disease when you're pregnant, especially postpartum. But so severe eclampsia or severe preeclampsia is pretty much something about the blood pressure that is then concerning to you for preeclampsia because they have symptoms. And so that would be, anybody that we think of as preeclampsia is probably going to be in the severe category, anybody that we would identify pre-hospital. And then we know that the difference in preeclampsia and eclampsia is a seizure. That's the difference. Once you have the seizure, you're eclamptic. The crazy thing about this, so we know the best treatment for eclampsia, preeclampsia, is delivery of the baby. The problem is this can happen after the baby's been delivered, and so that's kind of, so is treatment to get pregnant again? No, it's not. Treatment supportive, but I actually had a buddy of mine in residency whose wife had postpartum eclampsia, actually, and that kind of threw us all off. And she was put in the hospital, and she was given magnesium, and magnesium does reduce the progression to eclampsia. Interestingly enough, the data, if you look hard at the research, it doesn't show an overall decrease in morbidity and mortality with magnesium. But it kind of seems like, well, if you're not progressing to eclampsia, that would be a decreased morbidity and mortality. But the numbers don't really show that. If you're giving patients magnesium, you got to worry about mental status and about, you can monitor mental status and the reflexes. You can give too much magnesium. Now, to be honest, that doesn't happen very often pre-hospital emergency department environment because they give a lot of magnesium in OB and a lot more than we're used to giving. And so generally it's a lot more. But you need to pay attention to it. You need to notice if the mental status becomes depressed. And then, if a pregnant woman is having seizures, generally the magnesium is going to work better than Valium or phenytoin with that for the seizures. If you don't have other options, you do what you got to do. But those are the best choices. Or magnesium is the best choice for the seizures. I'm going to talk about peripartum cardiomyopathy. You could kind of argue if this is a spectrum on here. And this is there's not a lot of data on this. But it's basically it's a cardiomyopathy. The heart's big and they have CHF, and it's right around when the baby's going to be born. Can be before or after. I mentioned this because I know we had 2 of these patients within a 3 to 6 month period over in Cedar Park, and they both came to us, and they're pretty scary. My partner had the first one, I had the second one. There's a mortality rate greater than 50% in these patients, and so it's it's a near-term patient with just sudden onset flash pulmonary edema, and they this is, both of these patients have the classic pink frothy sputum that you see, altered mental status, getting intubated, things like that, and the treatment is delivering the baby, C-section, and I know both of the patients that we had, they came in, they got intubated, they got a crash C-section, both moms ended up on balloon pumps, and everybody actually did fine. Both of them came back and saw us with their babies and did really well. I know when I had mine, I was worried about it because I knew I'd heard about the first one, and so I reviewed the literature and stuff, and it knew that it was a greater than 50% mortality rate. So then when I got mine, I was like, well, the first one did okay, so statistically the odds are stacked against me this time. But they did real well. But I mention it because it's scary. You have a pregnant lady, which, as we talked about before, scares us anyway. Now you've got a pregnant lady that is also basically an immediate category CHF patient, which scares us a little bit anyway. So you've got kind of a double whammy here. And you just do what you got to do, really support the airway, get some positive pressure going with that. And I remember when my patient came in, they, EMS called and gave us a great heads up, and that's real important here. And the nurse called up and said, "Hey, we got this patient coming in, and can y'all send an L&D nurse down?" And I said, "Well, wait a minute, tell them to send an L&D doctor down." And they did, and it actually turned out that the obstetrician that came down was this patient's doctor and was familiar with her, and she had no history that pointed to something like this happening. So generally, this is what you're going to see. You treat the patient as you normally would. I don't know, what they really need to do is get, C-section. So kind of, ABCs with a lot of the other medications. I don't know if they're going to have time to make a big difference with that, but these patients may end up getting intubated pretty quickly. But just know that this entity is out there, and that way, if you see it, you at least say, "Hey, I remember hearing something about this. This is something that happens, and we need to, support ventilations and get them somewhere where they can get C-section quickly." I'm Dr. Ira Wood, and thank you for having me and allowing me to give this presentation.